Hey, Kristen. Good morning.
Good morning. Is
Happy
that you,
Monday.
Olivia?
It's me. Hey,
Great.
I'm presenting. Do you want me to drive?
If that's what you prefer, that's great.
Yep, sounds good.
Kristen, can you hear me okay?
Loud and clear.
Are you able to
We have
see?
board members.
Olivia, we can. Oh,
How was that?
we don't see the actual, we see the actual presentation, but we're seeing your side of the presentation mode. So we see the upcoming slides along with the current slide.
Yes.
It may just be that you're not clicking the right window to share.
Yeah, I think you're right. One sec, Kara.
No problem. Perfect.
Okay, is that better?
That's just right.
Okay. I was about to have to invoke our CIO on the phone.
Maggie, are you here?
Good morning. Yes, I am. Just let me know when you guys are ready to go on the record.
Are you ready? Yeah,
Yes,
we can go on the record. Ms. Sweetnam, are you ready?
Yes, I am.
We are now on the record.
Yeah, Maggie, we can go on the record. Good morning. Today's August 12th. We have 3 hospital budgets this morning. I'll call to order the Green Mountain Care Board's hearing, and first we'll be hearing from Grace Cottage. Ms. Sweetnam and Mr. Brown, is it just the two of you presenting today?
Good morning. Yes, the two of us will be leading the presentation, but we have our leadership team on the line as well, so you might be hearing some other voices.
Okay. Could you introduce and identify each person who may be speaking this morning?
Sure, absolutely. So this is Olivia Sweetnam, the CEO. Stephen, our CFO, is on the line. Chris Boucher is our COO and CIO, who's also on the line. Heather Boucher is our quality infection control lab director, who is also on the line. And then we do have some other leadership members on the line, but I think that's the majority of who you'll be hearing from today. We also have Crystal Mansfield, who's our director of rehab, on the line. So I think that's the majority.
Okay. So I'll have to administer an oath for anyone speaking. So I'll administer the oath, and then after I do so, say whether you agree to the oath or not, and then identify your names for everyone who so swore for the court reporter. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do. This is Olivia.
Stephen Brown, I do.
Heather Bush, I do.
Thanks, Heather. Chris, are you on?
Yep, Chris Boucher, I do.
Crystal Mansfield, I do.
Okay, I think that's everyone. If there's anyone else who pops in who has any evidence to give, we'll have to make sure they're sworn in. So I have Heather, Chris, Olivia, Crystal, and Stacy.
Stephen Brown.
I'm sorry. Oh, sorry, Mr. Brown. Sorry, Stephen. Yeah, bad handwriting. Okay, great. Well, I'll turn it over to you, Ms. Sweetnam, for your presentation. Thank you all for being here, and we look forward to hearing your presentation.
Wonderful. Thank you all. Thanks, Chair Foster. Thank you for having us this morning. We're looking forward to this discussion and have some slides prepared to walk you through. Also looking forward to y'all's questions and comments. This is obviously my first budget meeting with you all, but Stephen has been through many of these, so he'll be our strong, consistent member here as well. Lots of feedback to share, I'm sure. So we'll get moving here and advance my slides. So we have Dr. Otis here. I do love this picture. Just as a FYI to everyone, just last week was our 75th anniversary here at Grace Cottage. We're really proud of that. We do have an employee appreciation barbecue planned for tomorrow for us to celebrate our 75th anniversary. And the hospital mission and promise continues, which is to serve the healthcare needs of our community, to promote wellness, relieve suffering, and restore health. You know, we'll talk a little bit more about our focus on primary care and preventative medicine. But when we do have our community members here who need acute services, whether that's in the ED or on the inpatient side, of course, our goal is to relieve that suffering and restore them back to the best health that we can. Our promise to our community is that we go beyond patient care. And I think that anyone who has ever received care at Grace Cottage can attest to this. It's truly, you know, I've worked in hospitals all over Canada and the US, Louisiana and Connecticut, and also in Vermont. And there really is nowhere else like Grace Cottage in terms of like the holistic focus on not only the patient's physical well-being, but on their mental well-being, socioeconomic status, making sure they're discharged to a safe environment. Like truly, we care for the whole person to the best of our ability. So I think we fulfill that promise and continue to do so. This is our hospital vision. So we will provide personalized, competent, accessible primary care, rehab, wellness, prevention, inpatient care, and emergency services. We do focus on preventative care, and we'll talk more about that soon. We do collaborate with other agencies, and so we also have a slide speaking to that, but we're very involved in the community and really do focus on maintaining those strong relationships with our community that help us and help them, you know, with our common shared mission to take care of our community and to take care of the entire person. And then obviously our vision is that the community will embrace us, Grace Cottage, as a welcoming resource. And I would say as a non-judgmental kind of welcoming place, no matter where you are, we'll meet you where you are. The diversity and culture of our region was reflected in everything that we do. You can see our old Grace Cottage Hospital ambulance up here. Stephen Brown, who is on the line, who is our CFO, has driven ambulances for Grace Cottage. So you have a lot of multi-talented people on the line as well. And our below picture is some of our nursing directors, as well as our charge nurses and our inpatient side of the hospital. In terms of what we do here, so on our hospital side, we have 19 beds that are critical access, obviously, so acute and swing. And I thought it would be helpful for us to define swing, so we'll do that in the next couple of slides. But for the acute side, what that means for us Obviously, we don't have MRI capabilities. We don't have a kind of subspecialties. So for us, acute patients are often patients who come in through the ED and let's say, they've had a very complicated UTI, they've failed oral antibiotics, they've come in and they're displaying a sepsis picture in our ED, and we admit them onto the acute as an acute patient and the inpatient side. Let's say they need IV antibiotics and they're maybe a little bit hemodynamically unstable. Those are the types of patients we get under that acute bucket, complicated pneumonias, UTIs, that type of thing. And we can talk about the type of swing patients we see as well. We have a 24/7 ED. We have 2 nurses on days and nights. We have providers that are in-house for the ED 24/7. It's very busy. We have a slide on our volume, but that we are tracking this year to be our busiest year ever in our emergency department. So we'll talk about that as well. Diagnostic imaging. So we do have a CT and of course an X-ray as well. They're quite busy. We also have ultrasound, an ultrasound tech who does that as well. We have our lab, so inpatient and outpatient lab. And then we have inpatient and outpatient rehab. I think that and I'm sure Crystal Mansfield would agree with me, I think our rehab program is like one of our crown jewels. On the inpatient side for our swing patients, they just receive an immense amount of rehab. I think that's why Grace Cottage is so well known as a rehab facility. We have excellent therapists, and just the frequency with which they receive rehab on the inpatient side and then the outpatient side is just extraordinarily busy. And we will be finished a renovation of a building in November to give our outpatient therapists some more room to operate. Crystal has had many days recently with over 60 patients scheduled a day for outpatient rehab. So they're very, very busy. On the rural health clinic side, we do have primary care. We also have pediatrics. We have behavioral health. We have a therapist as well as 2 nurse practitioners, psych NPs, the prescriptive ability. We also have our spoke program, and then we have a community health team, and we do have a slide on that as well, just kind of outlining what that community health team does in terms of its outreach in the community. And then we do have our Messenger Valley Pharmacy, or MVP, across the street, which is a definitely a busy department for us, and really servicing the needs of our community. I think all of us can appreciate the fact that actually talking to a pharmacist or a pharmacy tech when you need something is incredibly helpful, something we can't always find from our big box pharmacy colleagues. So if we keep going here, I did want to just speak to this. So I think sometimes we get a little bit confused, and let me be totally frank. I came from a Medicis, a national home health and hospice company, worked in their corporate department, and before worked for a 25 hospital health system. And I don't think I fully understood what swing beds are and what they can do until I started here at Grace Cottage. And so swing beds are unique. They're unique to critical access hospitals. They're unique in how they work. And so these are hospital beds that can do both things. They can do acute and long-term care. They're usually used in rural areas, depending on our patient needs. And they're very, very important in bridging the gap between short-term acute care and long-term skilled nursing care, whether that's at home or like in a facility. I think sometimes people think swing beds are like a nursing home. And so we have to do a lot of education that no, this is a bed with a purpose. You're here for a specific reason. You're here to do work with therapy, or you have a skilled nursing care reason, whether that's IV therapy or wound care, and therapy as well. So we do receive a lot of patients who, are post-operative from an orthosurgery or deconditioned from a cancer treatment. I will say, and we talk about this a little bit later, I think we have the ability to market ourselves better to some of our larger counterparts, Dartmouth being at top of mind, where there might be some areas like post-cardiac surgery or other types of post-surgical patients that are good fits for us, who would be a good fit for us, who really could benefit from that kind of higher level nursing care and rehab functions before they're returning to home or long-term care, which, as we all know, has much less support from a nursing, pharmacy, or rehab standpoint. This verbiage is from the Rural Health Research Project. On the right, I was giving an example of Crossing Rivers Health, which is a critical access hospital, but we really liked their infographic. And if you see something that looks kind of like this from Grace Cottage in the next couple of months, you'll know where we got it from. But we're looking at doing some kind of retooling of our branding and just making it more clear how you qualify for a swing bed and what kind of services that we do offer. And I think another question people ask is like, okay, well, is critical access and are these types of swing beds safe? And when we have looked at the data nationally, critical access hospitals are actually quite safe compared to some of the other avenues of care delivery. So we do believe very strongly in the care that we provide. It's safe, it's efficient, it's high quality care. We got Heather on the line from our quality team who can attest to that. So we're really proud of the care we deliver here. I would also say that when we talk about volume, and of course, in the context of Oliver Wyman too, I think we've all seen a lot of data from that project, and we really do appreciate Bruce, Irene, and Danielle, their partnership in building out our report. We've had a lot of conversations with them and really do respect them and have, I think we've had a really great working relationship with them. But one thing I do want to point out, and there'll be a couple of clarifications here, if you just look at our admissions in terms of number of admissions for acute versus swing, you'll see that they look about equal, or at least not a huge difference. But then we talk about patient days. So for us here at Grace Cottage, as you would imagine, those acute patients that have like a complicated UTI and failed oral therapy and are, a little hemodynamically soft and come in to see us through our ED, they're not a long stay, right? They're here for a couple of days. We get them controlled with IV antibiotics. We can we can transition them. They become more stable. We get them out the door. We're not in the business of keeping our acute patients any longer than we need to, for sure. But our swing patients who come in, these are patients who might have and I can give lots of recent examples, but have had a hip revision from a hip fracture and popped out, needed to have a revision or intense wound care issues or complicated fracture healing. And so these are people who really need a lot of help from us, from Crystal's team on the rehab side, from medically, from our nurses, from our physician. We do have a hospitalist who's here. They rotate on a week-by-week schedule. So you can see here that when we talk about our total inpatient days, we are much, much heavier on the swing side than we are on the acute side. I think that's relevant because when you see the Oliver Wyman report and we talk about repurposing our acute beds, and when we talked about this with Bruce, we're saying like, okay, to who and to where, because we don't have many of these acutes, and is there a better place for them? I would argue no, because I don't think they need a higher level of care. I think we're the right level of care for these acute patients, the ones we keep. But there's not many of them as a proportion of our total days. And for our swing patients, this is the right place for them, without a doubt. They need that rehab. They need that kind of intensive care before they return to their home environment. So just clarifying, who is in our house at any given time. We also would say if anyone on this call from Green Mountain Care Board or anyone else would love to come, we would just love for you to come visit. So if anyone's interested in coming to see the inpatient side and kind of what that looks like for us, we would so welcome you guys. Please feel free to drop us a line and come visit anytime. For our ED volume visits, as I said, if we continue at our current clip, this will be the busiest year we have so far. I would also just say, and you'll see in the Oliver Wyman report, they have added this caveat at the top. So we went through this clarification with them. Oliver Weinman's initial report showed diminishing emergency room visits, and we really couldn't figure out the reason why. But then when we closely read the footnotes, their emergency room numbers were from individuals with a primary residence in Vermont. So as you all know, where we're located, whether it's in Dover that has between a 75 to 85%, depending on who you ask, secondary residence percentage, and the tourism population in this part of Vermont, it's significant for us. Significant number of people with second homes in Grafton, Townsend, Dover area. So I think that primary resident is not really a great picture. So Oliver Weinman has added that footnote in that slide, but you can see we continue to be very, very busy in our emergency room. And I think they do a really, really excellent job as well. And we'll talk a little bit more in terms of the telehealth support we have there. So as we get into our budget conversation, in terms of the summary of our budget proposal, and I know I sent these slides over in advance, so I'm sure you all have seen this, but we're meeting one out of the three benchmarks. So commercial rate growth 2.5, NPR at 12% due to volume, and I can get Stephen to speak to that a little further. And then operating margin at negative 2.3%. But right before I turn it over to Stephen to just discuss the NPR, I would say that we appreciate that the Green Mountain Care benchmark requirements operating margin is flat. And we do have a slide obviously on our operating versus total margins. I would say though that here at Grace Cottage, as an executive leadership team, we really appreciated SVMC's slides, their presentation, especially around their Thrive model. So how we're communicating financial health and well-being in the organization, and how we tie our projects related to our financial health into a broader messaging, like using that umbrella kind of Thrive model. So we're talking about how we can adapt something similar here to Grace Cottage to really talk about our finances and be more transparent with all of our staff, and also committed to seeing where we can find those small pickups, whether it's being more efficient with our staffing, whether it's adding clinic visits where it's appropriate, whether it's picking up some additional imaging services. And we'll talk about all of these in later slides. But I think that for us at Grace Cottage, we have consistently had a negative operating margin. I know I'm new to Grace Cottage, but I really do think that flat operating margin is a goal for us, and it's an achievable and feasible goal with concerted effort. And my job is to make sure that we're all aligned to that internally. So although you do see that -2 for our coming year, that is with a clear focus and goal to have it flat in coming year. Stephen, do you want to speak to the NPR?
Yes. Our NPR growth, as clearly can be seen by our budgeted rate increase, is not based on rates. It is simply based on volumes and not from adding any service lines or dramatically changing anything we're doing, simply taking care of those patients seeking our services. As Olivia just pointed out, the ED volume has increased. It continues to increase this year. Our budget for the current year, of course, was based on only the first 7 months of last year, and it continued up throughout last fiscal year. So that increase in volume is driving the ED revenue. And the only two things we did budget, as pointed out in the narrative, to change for the coming year, aside from our current level of patients, is a very slight increase in primary care based on hopeful new increased provider productivity and encounters based on our new practice management, being able to improve efficiencies there and get each provider to see one or two more patients per day. The bigger increase was, as Olivia discussed, we're renovating an existing space for our outpatient physical therapy department because we cannot meet the demand of those coming to look for outpatient rehab. And that will allow us more treatment space with the ability to add one more outpatient physical therapist in the coming year.
Thank you, Stephen. Appreciate it. I think, and I know we'll have questions at the end, but I would just also mention that to Stephen's point about like we have to care for whoever comes to our ED, of course. I would also say that although and we'll talk about this further as well, but although we have same day appointment availability for our existing patients, as we all know, urgent care type of access, and especially in this part of Vermont, isn't really robust. So as part of our new clinic building, as part of that design, new space, having that same day or type of urgent care access is important to us and is something we're planning for. So, perhaps some of that volume that we see in our ED, could it be shifted to that type of location? It's very possible. We will see. I would say our fiscal year 2025 budget goals is financial stability with plans to appreciate positive operating margin, as I've mentioned, to grow our primary care. As Stephen was just talking about, we do have Chris Boucher, who is our new COO, CIO. He has been here in a ISIT capacity, but with a nursing leadership background, who now is overseeing our radiology, ISIT materials management, and our rural health clinic program. And I think Lynn is also listening in. Our rural health clinic director are doing some really exciting work around team-based care models, as well as kind of strategically looking at appointment slots and times. And we anticipate we will see pickup there also. And then, of course, we have our plans for our new primary care building, which we have a picture at the end of this presentation. Of course, as Stephen was mentioning, growing our outpatient rehab, we have budgeted for an additional FTE for that. Crystal and her team have just demonstrated the astounding demand for that, and we anticipate that will continue to grow, especially with the current stable of patients they have, and wait times and demand for that continuing. And then, of course, focusing on cost-saving initiatives and operational efficiency as well. The summary of our budget request, so carefully thought out financial plan for the coming year, minimal price increase, as you guys have seen with the 4%, and really the charge is the minimum necessary to offset inflationary increases and operating expenses and shortfalls in reimbursement. We do have a slide talking about Medicaid, Medicare reimbursement. I would say it is in the fun time of an election year. We appreciate that we can't forecast, no crystal balls around here, what our tariffs will look like, especially if it's just China versus a larger kind of country agnostic tariff, as one candidate is proposing. So it's hard to really know what some of those pressures will look like, but we will march forward with the best knowledge that we have available to us. The budget of fiscal year 2025 has the same service lines as Stephen was mentioning, and then he also just spoke to the outpatient therapy and rural health clinic. Pharmaceuticals budgeted at cost currently being paid with 3.8% inflation based on projections from our group purchasing affiliation, not our own internal calculations. And then supply costs budgeted with 2 to 3% inflation expected. I think some of the risks for this do include reimbursement. We do have, as mentioned, we'll talk about our Medicaid reimbursement, but just kind of the general reimbursement landscape. A shifting payer mix. Of course, we have our Medicare Advantage plans that are very labor intensive for us and onerous and have been very difficult at times. And also our staffing costs. I will say this is something that's improved for us really very much, but hard to predict into the future. And I would also say delays in ED patient transfer due to system stress. I think this is less of an issue for us than some other hospitals in Vermont, but I think always, especially in some of our backlogged hospitals, can be problematic. And then, as I was mentioning, change in tariffs or inflationary pressures, it's just hard to really predict what that's going to look like at current time. I would say our opportunities, the design construction of our new clinic building, we're extremely excited about. Of course, we're about 50% of the way fundraised, a little bit less for that new building potential or projected cost of around 20 million. And we are about almost halfway fundraised for that new building. Outpatient PTOT, as we said, completed in November. That construction, knock on all of the wood, is actually going really well on time and on plan. Addition of imaging services with existing equipment. So what this is speaking to is the fact that we have realized that there are some additional imaging services we can do. So for example, low dose lung cancer screening is something that we in the past have sent out. We have a CT machine though. We actually do have the software to do that type of exam. So investigating that further, there's some, additional pieces that we need to have in place, like a tobacco cessation program, and making sure that our primary care providers are educated and, have the clear guidelines of when this lung cancer screening test is indicated. But we do send out about, I think the number is about 177 exams, and with proper education of our primary care providers, that number could be double. So looking to see where do we have some gaps and is it possible for us to meet those internally. There's also calcium scoring for coronary artery disease. That's another thing we could do internally, but it's a private pay service. It's a little more complicated setting up the billing side of things. So we're going to focus on low dose lung cancer screening first, but there might be other there may be other tests and other capabilities with the current equipment that we have. As I mentioned, we also are interested in growing our referral pool further. So not just kind of doing a scatter shot, but looking at, potentially the DRGs or being targeted with who we're actually marketing our swing bed program to. So of those patients that stay longer than, Dartmouth or UVM would have anticipated, that really do need that further rehab and nursing support, how can we really proactively go out and market ourselves to those individuals? And so we have some plans to do that as well. And then continuing our partnership with Dartmouth in our teleprograms, which we'll talk about here in just a minute. So the charge increase requested isn't adequate to produce an overall positive operating margin. Our work continues there. However, we are so grateful, and we're in such a unique position here at Grace Cottage that we have really, really overwhelming community support, which we so appreciate. So not only does that impact our total margin, but also, of course, fundraising for our new clinic. So that is something unique and to Grace Cottage that we just wanted to point out. The submitted budget reflects minimal operating losses, slightly better than those submitted for 2024. And then uncompensated care, both bad debt and free care, is budgeted based on what we experienced the first 7 months of 24. I would also say that the community benefit, I think Grace Cottage is essential to the community. We're really a strong, steady, continuous figure in this community. We do have that overwhelming support. Financially and otherwise from our community. We are also one of the largest employers in Windham County. Those employees do support local businesses and the local economy. And we've received so many Best Place to Work awards, including this past year, Vermont Business Magazine. We were the only hospital who won this award. And I would say that that's not an accident for Grace Cottage. I mean, and I know I say this and I'm a little bit of a broken record, but the culture here is truly special. I think especially those of us who have done a lot of work around quality, culture of safety, and just culture in healthcare. You see some hospitals who have very kind of strict hierarchies, who really adhere to kind of the old school medical model of hierarchy, and that really erodes psychological safety in hospitals. And I feel very strongly about that, and the research supports that in healthcare quality. And I think here at Grace Cottage, all of our staff treat each other, whether they're providers, whether they're nursing staff, whether they're environmental services, dietary, they treat each other kindly with respect and appreciation for each person's role. They operate on a first name basis. We all eat lunch together, and it means something for everyone who works here. And everyone's very proud of working at Grace Cottage. And I think that is borne out not only in these types of awards, but also recently, the Brattleboro Best of Awards. I think across the board, we do really well in this aspect. Partnership with other organizations, I do think that goodwill extends out as well. We do have a memorandum of understanding and a BAA with Turning Point, which do fantastic work. They actually presented to our med staff not too long ago and are coming in this week to meet with our nurses. But this peer counseling kind of support model for those with substance use concerns. So they will come into our ED or come into the inpatient side and meet with patients and discuss with them kind of a path or road to recovery if it's right for them. And if it's not, just figuring out how they can support them in their journey. And they do really excellent work. Also, obviously, Biata Home Health and Hospice. Our Senior Solutions or Area Agency on Aging, including our participation in the Wyndham Aging Collaborative, and working closely with BMH and the executive team for the Aging Initiative as well. And you can see many below. I mean, Valley Village is our next door neighbor almost. We are in conversations with them. We'll go into our third meeting about trying to set up a LNA program or licensed nursing assistant program, because the Brattleboro program will be no longer as we understand it. So how can we support our own pipeline through that program? Also our CARES organization, so whether that's Townsend CARES or Brattleboro CARES, but supporting and working with those organizations, Mover obviously as well, and then Meals on Wheels and others. Rescue obviously is a wonderful partner for us. We've got VEMSA right down the street. We do utilize their space for example, our Evade program, which is our workplace violence kind of preventative, de-escalation, but also physical safety program. So they've been great partners with us. And we also are really talking to Drew and his staff around the really cool work that they're doing in Brattleboro, pre-post-op visits for ortho, but then how we can really kind of explore that forward deployed model and see if that's possible for us here at Grace Cottage as well. For workforce development, you can see here some of our amazing nurses. We did some for Nurses Week. We had some what did we call them? Shift essentials fanny packs, and we had all neon colors, but everyone ended up with pink ones. But we do collaborate with many schools, including Vermont Tech for student rotations, high school students. We have UVM med students here. We definitely offer many Pride Month events and really celebrate various healthcare worker appreciation days and weeks, not just nurses. And then some of our awards are below. For equity, that committee was started in 2019. Made up of members who actively engaged and advocated for LGBTQ plus community. We have community members, not just employees, which I think is really unique and great because we not only get our own employee or provider experiences or thoughts and opinions, but also our community members as well. And we've revised policies and procedures to align with HRC's Health Equality Index and have won many awards for that as well. And I think we talked about those in previous year presentations, it looks like, from when I was flipping back through those. In terms of our look back, so previous year's budget, our agency staffing is over quite a bit in the first 9 months of the current fiscal year. I would say that I'm very, very excited about the fact that our agency staffing is almost come to a close. And we've done a lot of culture work in the nursing side of the house since I've started in February. We're in such a good place. We've hired many full-time nurses in our ED and inpatient side. I would say that one thing to just consider here, although I think at one point, and I saw this in previous year slides that were presented to you all, EM staffing was a temp staffing solution that was brought in. And although they're not travelers per se, they were quite a bit more expensive than our travelers. So really the focus was not only on controlling that traveler expense, but also any of our temp staffing expenses. I'm proud to say that we've really gotten a handle on that, a hold on that in the last 60 days. And heading into the fall, we should only have one emergency room agency staff and 2 inpatient, which is much lower for us. And each of those are considering coming on full or part-time for us. So the nice thing is we do retain many of our agency staff as well. Our goal is to have all employed staff by 2025. We have used contracted labor not only in nursing, but also diagnostic imaging and physical therapy. I would say that the rehab reliance on agency staffing is very low, very low. I think they have 1. Diagnostic imaging, though, we have relied heavily. It's been extraordinarily difficult for us to find diagnostic imaging professionals. There is not a single ultrasound tech program in the state of Vermont. So we obviously need to recruit outside. It's difficult with affordable housing or lack of affordable housing. We're looking at alternative kind of staffing models for diagnostic imaging to make it more attractive, I would say. But we continue to look for ways forward there. It's definitely an area where we struggle to just recruit individuals. Okay, so I would say I just wanted to, one of the budget questions was around our telemedicine utilization. We do use tele-ED, neuropsych, and pharmacy. Our patient experience is very positive with these programs, and the fiscal impact is pretty limited, about $150K per year for the first 3 programs, and it's a flat rate. It doesn't matter how much we use it, and so we encourage our staff to use it as much as possible. And interestingly, tele-ED was actually telling us, and we do frequent meetings with their leadership team, their physician and admin and nursing leaders, that about half of the tele-ED calls that they receive, not that we do, but just Dartmouth for tele-ED holistically, about 50% of the calls they receive are actually nurse to nurse. So there's not really a provider involved. But at a small hospital like Grace Cottage, that makes sense. I mean, anyone who's been in the ED, when you have a complete crash patient who's come in and is fully crashing and you're intubating and running a code, two nurses isn't a lot. And so sometimes you need that extra set of hands to do documentation in the background, who can run medication compatibility checks for you, who can just be eyes in the sky to help you get through those situations. So we really do appreciate their partnership, and of course our providers. So our majority of our providers in the ED are APPs, so physician assistants and nurse practitioners. So being able to hit the easy button, as we used to call it at one of my old hospitals, just hit that easy button, is that if you need a second set of eyes from a provider standpoint, or hey, I've really got to the end of my rope here in terms of what I can think to offer, what do you think, is great, but also they can help facilitate transfers at that point. If they're seeing, they're looking at it and they can anticipate what they're going to need on their end as well. I just wanted to show you some of the data that we get back from them. It's really helpful for us. So we see, our discharge dispositions, which day of the week we're busiest in terms of how often we're activating tele-ED. Similarly for tele-neuro, you can see time of the day and day of the week. It's kind of comical, or maybe not really, but we seem to have a different busiest day of the week for tele-ED and tele-neuro both. So it's like, you never know which day is going to be busiest. It's just kind of across the board. But this is helpful for us too in terms of planning. You can see that we do have a lot more tele-neurology calls than tele-ED generally. We do see a lot of those kind of TIA stroke pictures. Of course, with our aging population, that makes sense. In primary care, we do continue to focus on expanding those services. I think we've talked through this. I would say that when we talk about our new clinic, I think most of us have been to primary care facilities, or especially those that are somewhat newer, where you're used to there being multiple rooms for a provider. So a provider sees a patient, and then they can go to the next room while the nurse is finishing that visit, whether that's administering immunizations, doing an after visit summary, whatever it takes to kind of close out that visit. When we have one office space per provider, it makes it extraordinarily difficult. We are in a log jam for our providers and their support staff in our current space. And again, anyone who would like to come visit, we welcome you with open arms here. But it's a very old house with creaky floors, with narrow hallways. And so we really do run into that. We're kind of jammed from a productivity standpoint. We physically can't get people kind of in and out as fast as we would like. Our new clinic, where we will move to 2 rooms per provider with support staff, will make us so much more efficient. It's really exciting to think about. I wanted to mention our home health services because there was a question around if we're planning on providing more VNA type of services or VNH. We don't have any current plans to have kind of forward deployed home health services. We are talking with Rescue to understand some of their models and potential opportunities with Drew and his team. We don't really currently have any more staff or time, physical space to extend ourselves any further, but we do have a community health team that will help people whether they're a patient or not. Claire is such a fixture in our community, and really the way she can connect people and services is really remarkable, and she's so valuable to us. So we do have that service for our community. We do anticipate raising over $1 million in fiscal year 25. That, of course, helps us with purchasing equipment, operating expenses. And we do this through a multitude of ways, obviously meeting with our individual donors and the different events that we have. I will also say this is the only place I've ever worked where we have people who come for an ED visit and leave a $10,000 check on the way out because the ED experience was just so far and above anything that they had experienced before. It's remarkable, but it's as Andrea likes to say, who's our foundation and philanthropy expert here at Grace Cottage, that we really do the work. We do the clinical work of encouraging people to be so loyal to Grace Cottage because we do treat people with so much respect and care and love. That it makes it a little easier for her to do her job. Capital expenditures, IT mainly, but then obviously the start of construction for our new rural health clinic. And then almost to the end of my slides here, but I wanted to answer your questions about underfunding of Medicare and Medicaid. So is Medicare underfunded? Less so than Medicaid, obviously. We are eligible for 101% of allowable Medicare costs and services. However, due to the 2% Medicare sequestration, we're only paid 99% of costs. So that's relevant here, obviously, for our budget, but especially Medicaid. So is Medicaid underfunded? Holy moly, is it ever. So based on our 990 submissions, our shortfall payments versus actual cost to provide care, so not charges, but our actual cost is 2.4 million. And then of course we have our provider tax. So our total cost that we pay to care for Medicaid patients is 3.4 million, which is hard. That's a hard pill to swallow because we are so committed to our community. We are committed to our Medicaid patients just the way we're committed to other patients, but that's a massive cost to us. That is our negative operating margin. And then just to, kind of drive that point home, this is a true recent patient. This is a patient with substance use, injection drug use history, who's unhoused. She is a wonderful patient. We love having her here. She's incredible. She's just a bright light on the inpatient side. However, this patient was here for under a month. Was a complex picture, required IV antibiotics for endocarditis, which is a heart valve infection you sometimes see in injection drug use, especially patient populations. The total facility charge for her stay was about $54,000. And now that's IV medications, she get the full care. Medicaid paid us about $8,000. So 14% of our billed charges. So when we talk about health equity, I mean, it's just difficult because we do take a bath financially when we're caring for these patients, as you saw from the previous slide as well. So we are committed to our community, but it makes it difficult from a viability standpoint when the Medicaid reimbursement is so poor. So the last thing I'll talk about is just our Act 167. I would say that the statewide recommendations, especially when we talk about interoperability and affordable housing, transportation, we really support these. We really support these recommendations. I think a lot of the town hall meetings talked about waste in healthcare. Let me tell you that when we have, when we're on Cerner, other hospitals who are on Epic, or even other hospitals on Cerner like Brattleboro, when we're doing manual faxes for referral management, and then we're getting that information faxed back, we're uploading it into the chart, we're manually closing out a referral. Is there waste in healthcare? Absolutely. Is it required work for the unfortunate kind of clunky system we currently are operating in? Also, absolutely. The same for prior authorizations, our Medicare Advantage patients. So we will work on reducing the inefficiencies that we can control the best way we can. But some of it's baked into our system that does not have the type of interoperability and seamless communication that we'd like to have. I would just also say the state level solutions that they recommended, including top of license practice, is something that we also fully embrace, especially as we look at our new clinic. How can we use our MAs, LPNs, and RNs truly at top of license, as well as our PharmDs. So this is a picture of our new clinic building. I would say that in our hospital-specific recommendations, there were conversations with Oliver Wyman about, as I mentioned, repurposing those acute beds. We really didn't get to a solution on what that might look like. In discussions with Bruce, no clear solutions for what that would look like. Of course, we don't want our patients to incur additional expenses by transferring them somewhere else, especially when they don't need a higher level of care. Bruce really reinforced and is very much a supporter of our primary care building and expanded primary care services. That was something he really focused on, and told us we were very much on the right track. There was a conversation as well about REH, rural emergency hospitals. I would say that designation, the first hospital only went live the January of last year. I don't know if we have too much clear information on the impacts of that as of yet. What we do know for certain, though, is that we would lose our 340B program and would need to shut down our MVP pharmacy. And so I think that would be quite a community hit. It's not something that we are very excited about doing, that's for sure. So really, we are continuing to focus on our primary care expansion, becoming more efficient there, as well as on outpatient therapy, meeting patients where they are and where they need us. I just threw this in here too, although I'm sure many of you have seen it, but bright spots from our community meeting for Oliver Wyman, which we worked together with them for our presentation. So my last slide, I just wanted to reiterate, we're fully committed to working together. We're very open to new innovative models. We are inquisitive. We want to learn new ways to do things. We're invested in our community and as a partner at the local and state and federal level. And we are committed to being good stewards of our resources as well. We don't take it for granted. So I think that's it from my end. I appreciate y'all's patience and attention to our presentation. So thank you. I think I'll leave my slides up for a few minutes in case I need to flip back for any questions, but thank you all.
Thank you very much, Ms. Sweetnam. And you did a great job in your first time. So congratulations and thank you for doing this. I have a few questions, probably not too many. On inpatient services, it looks like it's about $2.1 million in budgeted revenue. Is that right?
Stephen, do you have that in front of you?
That would be just the acute patients.
Just the acute patients. Okay, so the swing beds, when they're not being used for acute, is not counted towards that 2.1?
No, the 2.1 is the actual billed acute stays, and then the swing bed revenue that's budgeted of 9 million is for the swing bed patient days.
Got it. Okay. Thank you. And then in terms of your providers, how many physicians do you have serving the inpatient services?
We have one hospitalist. As Olivia said, they rotate on a week-by-week basis from 8 a.m. Monday morning till the following 8 a.m. Monday morning. And that one individual is responsible 24/7 for all of the patients in the building. They, on an average, we had them average out, they spend roughly 80 hours, give or take, in that 7-day period. They aren't physically in the building. They're here every day, but they don't stay here 24/7 because we do have, although they're always available after hours, we do have the emergency department provider in-house 24/7, and they are the first line of resource for the nursing staff if they have a question about an inpatient. And then if they don't, they can always call the hospitalist.
Okay, so you have one hospitalist, and then do you have one full-time physician in the ED?
There's a full-time provider. It's actually almost always a physician assistant, but they do 12-hour shifts, 7A to 7P and 7P to 7A, and they are in the building all the time. And the RED and inpatient floor are connected. I mean, they're side by side.
I'm going to take you up on the offer to come and visit. I haven't been able to yet, but I will do so,
Okay.
hopefully soon.
Excellent.
On the ED use in 2022 is 2,497 and 4,220 for 24. What are you budgeting for 25?
It was budgeted at the same level that it was at for the first 7 months. It's actually picked up the last couple of months. I believe the projected, let me find it here. The projected and budgeted number for 24 and 25 was just under 4,000, 3,950. But the last, like I said, that was through April, May, and June have been back up to being high again. So on track, we're budgeted or looking to be where she's at. So currently our budgeted amount is less than that 4,200.
Okay. Is 4,200, that's the projected for fiscal year 24 or the budgeted?
That's the projected if they continue at what they've done the last couple of months for the next 2 months, this month and next.
Okay. So that's about 11 patients a day. Does that sound about right?
Yes.
And it's my calculation, I'm not a CFO, but I'm calculating a 69% increase from fiscal year 22. What's driving that increase in the ED utilization?
Definitively not sure. I think my primary gut reaction would be that it's two things: a lack of primary care availability in Brattleboro area. And at the same time, Brattleboro does have an urgent care center that originally was open 24/7 and it has not been for a while. In fact, last I knew, I think it's only open 12 hours a day. So my presumption would be that people that would have been going to that urgent care center now, of course, have a choice between Brattleboro's ER or our ER, and a lot of them come up here. But that's just a rhetorical guess, if you will.
Yeah, I would
Sure.
agree. I would agree with Stephen. Like, I think it feels like the secret's out from our ED, especially like post renovation. They're really, really skilled clinicians. We have nurses who have traveled in their past at much larger facilities. They're really very skilled and competent and kind of handle anything. And I think the Brattleboro ED, similarly, extremely skilled, but does have a really high percentage of mental health or substance use kind of hold patients in their ED generally. And we have found that, and this is anecdotal in talking to patients, but if they know that they're stable enough that they can drive to see us, also our wait times are generally pretty low, especially compared to a Cheshire or up north to Dartmouth. It does feel like that is driving some of our volume. And then, of course, to Stephen's point, there are no 24/7 urgent care offerings. So anything that's kind of happening after 6 p.m. Is coming into the ED. Do I think that's ideal from an ED utilization standpoint? Probably not, but it's the current milieu we're working in.
I think probably also in the last couple of years, just again, anecdotally, but people are traveling more. People weren't traveling to Vermont particularly for vacationing, if you will, much in 2021, 22. And the last couple of years, there's a lot more people around, period.
Yeah, we definitely have a lot of tourists and second home seasonal residents who come in. And that's the point too, like they're not established anywhere around here. So, they don't really have the option of kind of popping in to see their established PCP.
And, having these patients served in the ED that could be in primary care, urgent care is certainly expensive for the system. What are your plans and strategies to get them to urgent care or primary care to fill that void so that they're not going to the ED?
Yeah.
Well,
so
part of that would be assuming that they're here Monday through Friday, 9 to 5. I think when we look at a lot of our ED patients are out of town. They're not local people that would otherwise be going to primary care if we could fit them in. A lot of them are Saturday, Sunday, after hours. We do have the ability and generally fit, particularly our own, primary care patients into the primary care clinic during the day if they need to be seen urgently. We don't have a lot of those people walking around the building to walk into the ER. So, go ahead.
Oh, I agree with Stephen, but also like as part of our clinic, our new clinic. And just to be clear, like that new clinic isn't giving us like tons of extra space to play with. It's really like appropriately, and not even appropriately, we've had to do some rearranging the spaghetti, as Lynn likes to say, in terms of making sure that we have the space that we need. It's definitely not additional or much extra space for us. It's more appropriate number of rooms for clinic providers. That being said, we are trying to carve out space for an urgent care area. So it's nice for our providers. Sometimes our providers like that break of urgent care. It's real episodic and kind of a quick day for them. So sometimes providers like that break of doing urgent care. So we are definitely looking into that model for the new clinic. We don't really have space to do that right now. And I assume that would decant some from the ED volume. And even if we could do extended hours there, similarly, it obviously wouldn't help our overnight volume in the ED. There's just really no option for people around here, 7 to 7 overnight.
Have you considered extending the hours of the clinic?
Yeah, we've talked about it. We don't have current solid plans, but especially in our new clinic, we've talked about extended hours. Yeah.
But the 11.
Sorry.
I'm sorry.
I was just saying it wouldn't fix our overnight problem.
Out of the 11 or so patients in the ED on a day, do you have directionally a sense of how many of those could be treated in urgent care or primary care?
I feel like if I told you anything, I would be guessing because I don't have the percentages in front of me. We could definitely kind of pull that data based on triage level and use that as an approximate, as an approximation. But I can get back to you on that. I don't want to guess.
Okay, fair enough. The provider productivity, I think, Mr. Brown, you said you're trying to increase 1 or 2 more patients a day for primary care.
Yes.
What's your average currently for patients a day in primary care?
Chris, you just ran that, you said, didn't you? Is it like 11?
It's 11 with behavioral health. It's probably more like 10 if we just looked at primary care.
So looking to up it to 10, 12, or 11 to 13.
Right. As a starting point. And unfortunately, there's only so much we can do in the existing space to make more productivity. I mean, as we said, we're working on processes and things like that. But unfortunately, there's a lot of the providers only have their office/exam room, period, and there's no room to have a second exam room. So there's not a lot we can do until we get into our new building to increase much beyond that.
I would also like to add to clarify that we're still operating in some respects in a post-COVID appointment durations, and we're working towards some 20-minute appointments had been extended to 40 minutes. That'll offer a slight uptick very easily in the short term.
Agreed.
It looks like you didn't have benchmarking data. Do you use anything for benchmarking provider productivity?
Chris, I'll
Not
just- too.
currently, but Chris is looking into that.
Yeah.
We're evaluating MGMA. We've also been reaching out to neighboring peers.
We plan to participate in MGMA's survey for next year, and we'll get that data then at a discounted rate. There's obviously other vendors as well, but I think we're leaning.
I could say we're in
Okay.
the process of more aggressively looking at benchmarks, and the challenges with our unique rural environment and current physical landscape layout. It's hard to find true comparisons, but we're working through that.
I also think that's
And then,
I'm sorry.
no, I interrupt you. Please go ahead.
Well, I was just going to say that I do think like this, I mean, I think there's a couple of things. I think Chris and Lynn are working really diligently on standardizing practices in the clinic. I think as Grace Cottage has grown, there's been some kind of individualized kind of practices that they are working to standardize into there's one Grace Cottage way instead of multiple provider ways. I know at every hospital I've ever worked at, that's been a challenge, but I think in primary care, the more we can streamline that, the more efficient that we will become. So I think there's work to be done there. And I think the conversation that I was talking about earlier in terms of the thrive, to use SVMC's terms here, I think part of this is having candid discussions and being really transparent with this data. I think that we have work to do there, not only with benchmarking our own internal data and then finances and kind of clinic productivity. I think Chris and Lynn are starting some really great work in that area too. And I think that will be really helpful in terms of driving consistency and standardization in the clinic.
And then you gave the example of the patient who was $54,000 and you got paid $8,000. Do you have a sense hospital-wide what your Medicaid cost coverage is? That example is 14%, but I was curious if you had a sense of over all of the patients, what percentage of the costs are covered by Medicaid?
I can give you that. Hold on. I just find the right piece of paper. 47%. They're actually paying 47% of our cost if I do the facility as a whole.
Yeah, okay.
Yep, and we just obviously have a limited ability to make that up on the commercial side. I thought one of your presentations was interesting in terms of like the most significant factor in commercial rate increase was the leveraging kind of the size, the kind of group, not purchasing power, but ability to impact. We obviously have none of that because we're so teeny tiny. So we don't have as much of an ability to make that up anywhere else, obviously.
Right. And then on the travelers, you said you were 1.2 million over fiscal year 24 budget.
Right, because we've had throughout most of this fiscal year, in the nursing department, we have had as many as 7, which is unheard of for us, including 2 LNAs. We've only ever used RNs prior to that, or needed travelers, I should say, for RNs. We've also had 1 physical therapist the whole year and 2 diagnostic imaging most of the year. And if all goes well, as Olivia said, we will be down to hopefully none or just 1 in nursing by the end of this year. And I know Crystal at the moment is interviewing a physical therapist in hopes that maybe we can be down to none in that department as well, though I think we probably will still have 1 for a while.
So you have 30, as of May of 24, you had 31 nurses in total FTE, and then you had an additional 7 travelers in 24.
No, the number that's budgeted, wait a minute, which report are you looking at? Because they're in the total FTEs, but are they on a separate line? Trying to remember the one.
I'm looking at the I think it's the workbook paper, the staff turnover document.
Let me pull that up.
Well, let me ask you it this way. Is it 24 nurses and 7 travelers, or is it 31 nurses and 7 travelers?
Good question.
That's just vacancies. So there's 8. Oh no, there were 5 vacant in the workbook submission you're looking at.
Yeah,
Staff
sorry, I'm in the
turnover and
employed.
vacancies.
I'm in the employed column. Employed as of May 24 says 31.8 FTE nurses.
No, this is only turnover. Right? There's 31 FTEs of nurses, of which 5 of them are vacant. So at that point, we had 5 travelers.
Got it. Okay. 31 employed, 5 travelers.
Correct.
Got it. Okay. Okay. I don't have any other questions. Thank you very much for your presentation and answering my questions. Any other board members?
Sure, I can jump in. This is Tom. Hello, Olivia, and team. I'll join Owen in welcoming you. In my early career, I was a physical therapist at Dartmouth Hitchcock in a spine center, and I became pretty well aware of Grace's swing bed capacity. It's an important need. We relied on it at times, and I just wanted to mention that. My role here is to review all the material you submit for your budget and then comment and ask questions about it. So I wanted to just start by saying I noted the primary care and rural health focus. I think that's excellent. I think you're on the right track. I also noted in your narrative, there was a mention of IHI's age-friendly health system project. That makes great sense with the swing bed focus and primary care and rural health. And also I heard in your presentation the terms like just culture, safety and reliability. So those efforts may have been underway in years past. But this is the first time that I've heard those kind of high reliability terms, specific terms used with Grace. And I think that that's great. I think there's a lot of really good stuff going on. So just to reorient myself, your operating margin is budgeted at minus 2.3%. The total margin is around 12 for the upcoming year. Is that correct?
Yes. And part of the total margin is because of including the CON that we do have to start our new primary care clinic. It is currently scheduled to break ground, if all goes well with the Act 250 permit, in April of next year. So there will be significant capital fundraising toward the first construction part of that project recognized in next fiscal year's budget.
Right. And that fundraising project is the 20 million project, correct?
Yep.
Right.
Yes.
Do you know the range of donated amounts and the average or the median? I'm trying to understand if this is, it's been known in the Upper Valley forever that you have a lot of money that's coming in, but is it a few wealthy donors, or is there kind of, is it widespread support? How do you understand where that money is coming from?
For our fundraising as a whole, or specifically for this capital project?
I'd like to hear an answer to both.
We get widespread community support throughout the year. So the roughly $1 to $1.5 to $2 million we get every year to help us with our operating is, and Andrea can chime in if she would like, if I don't say it correctly, but is everything from a lot of $5 donations up to, you know, $10, $15, $20,000, usually $150,000 or $100,000 donation a year. And the capital project is exactly the same. We have everything from a lot of $5 donations up to, at the moment, the highest one is the person who started off the project, which is $5 million. She's received, I believe, at least two $1 million ones at this point, and lots of different multiple $1,000 ones who are up, they're up to almost half of that goal already.
I would just say though that like, and Andrew can correct me if I'm wrong here, but I like Sharma and Andrea are fundraising experts, like to say that the clinic is in the loudest silent phase ever. So I would say that there's been a lot of I would say that for the clinic specifically, Stephen's exactly right. For the general kind of fundraising, there's lots of the $5 donations, but that kind of focus for the clinic of like this very broad kind of like all comers message for fundraising for the clinic. They're still kind of technically coming out of that silent phase. So much of many of the donors have been large donors.
Yeah.
And I think there are, and Andrea again can correct me, there are several large donors who truthfully are currently waiting for us to get our Act 250. They weren't going to commit until we first got our CON, which of course took a while. And now that we are in the Act 250 process, once we got that, you know, once we actually get that and they know it's going to happen, if you will, then there are several large donors waiting for that to happen.
Okay. That's helpful. On page 3 of your narrative, you answered the question about community benefit by noting the size of donations that you're receiving, and also noting that you employ people from the community. Neither of those is considered a traditional community benefit that would be used to justify a tax exemption. Are you familiar with the Lown Institute's Fair Share Index?
I'm not.
I am not.
All right. So it's Lown, L-O-W-N, but pronounced like gown. And they look at a hospital's community benefits and their tax exemptions in dollars. And in 2023, your community benefit, as they documented from your tax filings, was $317,931. while you received 1.46 million in tax exemption. So that's, you received 1.1 million more than you contributed.
How are they getting that on our tax filing? I mean, to
I'm
be
not-
honest, part of the, no, I'm just curious if you know the answer to this question.
Yeah.
Like, for instance, the Medicaid shortfall is considered on that Schedule H as part of your community benefit and justifying your tax exemption as well.
Right, right. I know, and I think that that's somewhat controversial. I'm not sure of their exact methods.
Okay,
But I do know that they're open and transparent about it. So if you wanted to give them a call to understand how they arrived at that, I'm sure that
okay,
they'd talk with you.
okay.
On your turning to the profit and loss statement,
Mhm.
bad debt amounted to $395,000 in the budget for 2020, and just over $1 million for this year, or for 2025. While free care was 212,000 in 2020 and 553 for 2025. So it looks like the debt is rising quite a bit faster for your community than the free care that's being received.
It is. And truthfully, you hit the nail on the head when you started with 2020 budget. COVID, truthfully, and
Yep.
not to keep bouncing on it, but so many people that had good health insurance either lost it, or health insurance deductibles and copays, the things that make up bad debt. A lot of our bad debt have just continued to increase due to people either not working or not having the coverage. In all honesty, I think that a lot of that bad debt, or I know that a lot of that bad debt would be considered free care if the people would actually fill out the reduced fee application. But they don't, especially around here, more so on the local people. They don't want anybody to see their income tax returns in the local community. So, I mean, I know there's a lot of people that are on the bad debt list, if I looked at it, that certainly should be free care, but without them filling it out, you can't call it that.
Well, Stephen, I appreciate the candor with your response and about it. That was probably the best answer that I've heard. And you beat me to the next point, was that according to ProPublica, about 60% of people with debt would be eligible for free care had they been screened for eligibility. And I know it's a challenge, but I just wanted to share that information back with you all, because I, as I started out, I experienced what you do. I know firsthand how important it is. And I believe in what you're trying to do. In my current role, I review the material you submit and then ask questions about what I found. So I'm doing that, and hopefully we all get better together.
Yeah, we actually do. If I think it said it somewhere in there, but if it did not, we actually employ a full-time resource advocate that's embedded within our her office is actually within the rural health clinic, but she does the whole facility, where she actually reaches out to every person who has a self-pay balance over, I forget what the limit is. It's a pretty low limit, to make sure everybody realizes they are eligible for reduced fees, and is happy to help them fill out the applications and get them to them. But it's getting them to fill them out.
Yeah. Yeah, I wonder if as your revenue grows, you've budgeted quite a bit over the guidance, and it sounds like it will be growing. That may be an area to put some of that revenue toward. The RAND 5.0 data has been talked about. I know Bruce used it in his presentation. Your total facility price, according to that data, comes to 249% of Medicare. And your break-even price, the way that they calculate that, is 116%. That's a gap of 133 points. And RAND considers that gap a measure of efficiency. The closer those two numbers are, the more efficient the hospital is. And 133 points is large. It's not the most in the RAND data, but for example, last week we were doing this with a hospital and their gap was 11 points. So that may be some of the space concerns you've been talking about with productivity, but it seems like that's another data point to show
Okay.
that you're on the right track looking at productivity and efficiency.
That's helpful.
Yeah. RAND also has quality metrics by Quantros that they look at quality and reliability. And they're one of the few quality metric sites that have aspects of reliability and safety built in. And you're in the lower part of the middle quartile. And I'm just, I know you might not be familiar with them, but I was hoping to use this as an opportunity to just hear your thoughts about how you assess quality. And I think Heather, you mentioned, is the quality person. I just try to understand more of what where you're at currently and what direction you're trying to head.
Hi, can you hear me okay?
Yes.
Yeah, so I mean, we assess quality in of course, different ways. We have our standard quality measures that we follow. So I'm sure you're familiar with BPQ. So we participate in a lot of quality projects with them. So we've done the suicide project with them. We also do the Medicare beneficiary quality improvement project. So that data, we're tracking various quality measures such as median time ED to arrival to discharge, left without being seen, our CLABSIs, our hospital-acquired infections, serious reportable events, different things to that. We of course have each of our quality at our meeting, each department comes to the quality meeting with a quality project, and we focus on that while we track that. We don't use Quantros, we use SQSS, which is more geared towards critical access hospitals. I know a few of them in Vermont use those, but all of these are oh, kitty cat. So all of these are reviewed, at different committees that everyone attends. Yeah.
Are you do you do any benchmarking with those data? Are you part of a group that you learn with or do anything like that?
So more like, well, of course we have VPQ, but more benchmarking. We use the standard, like the CMS benchmarks for HCAHPS and different things like that, whereas NHSN for our hospital acquireds. Of course, we look at Vermont report card and look at that, but it's more based on, and Press Ganey we use for, like I said, our surveys. So those are more of our we do Blueprint for Health for the clinic. So that, is looked at with patient-centered medical home benchmarking that way too.
Great, that's helpful. So I imagine you can see what I'm trying to do here. You're asking for a 2.5% price increase, a 12% NPR. Your total margin is quite large. It would be what would make me more comfortable about approving the request and would make me feel good years going forward is if we were able to see how you used that revenue to address the community benefit deficit, the community needs, and the inequality concerns, right? And so what are your priorities, your objectives, your key performance indicators to address those things? there's a lot of good going on. But you are asking for more than what we've written for in guidance. And so understanding how that's going to be used would be helpful. Chair Foster had a conversation about people and ED visits, and I immediately went to, I know that area around Sunapee and around Grace. And yes, there are a lot of people who spend 3 or 4 months there, go back to their primary home for 3 or 4 months, come back for 3 or 4 months. And I'd worry they're using an expensive site like an ED for their primary care needs. And so that'd be another thing about the revenue that's coming in, trying to get a handle on that and see if it's possible to redirect any of those patients toward a lower resource setting. You'll have one when you open the primary care facility, but that's something to look at. And the other part, I was worried when I started asking about the donations coming in and trying to get a sense of the gap that may exist between the wealthy people that vacation and sometimes live a good part of the year there, and the folks that are born there, raised there, live there, and aren't from wealthy families. And we know across the state, people are struggling with mental health concerns, substance use disorders. And I wondered what proportion of those emergency visits are due to that. And those conditions haven't been mentioned in your presentation. So with all the good things going on, I don't want to lose sight of the growing problems of death by suicide in the state, and making sure that we've got systems and processes in place for that. But just thank you so much for the presentation, all the material you submitted, and your willingness to talk with me about some of the questions I had after reviewing the material. I really appreciate it.
Thank
Tom,
you
I was
so
also, go ahead. I was also going to mention that, as a part of our whole community health needs assessment process, we work closely with both Brattleboro Memorial Hospital and the Brattleboro Retreat to address, the needs of our community in this area as well. And I was also wondering, did you just say people coming to Sunapee? We're nowhere near Sunapee. We're over an hour, well over an hour away.
I'm sorry. I might have gotten it confused.
It's all right. I just wondered if you knew where we were.
I do. Townsend.
Tom, thank you so much for your comments. Those are really, really helpful. Definitely something to think about. My background is also in quality, and Heather does such a fantastic job here. And I think like our internal quality, tracking the number of SQSSs, so the number of actual occurrences that we put in, I mean, the more the better. And we actually just did an RCA last week on an ED intubation that we thought could have gone better. So I'm really proud of the quality department. And also we've talked about increasing our sampling. So, of course, most places sample a percentage for Press Ganey, and we're in conversation with how can we kind of drive up our sampling so we can get more responses to actually have enough denominator to do more benchmarking, because that's part of it, obviously, is that we're little. But I think your point's well taken too about mental health and substance use. I know one of our providers kind of left for he and his wife both left kind of on a hiatus and did some very rural work in Hawaii in primary care and bike traveling, and he was saying his panel since he's come back has really changed, like so much more substance use. And so I think, and our med staff, they do a really fantastic job. Every med staff meeting, part of that is education, and we had some of the retreat staff at the last med staff meeting kind of talking about the esketamine work they're doing in refractory depression, which was so exciting. And so that started our own kind of process here of viability of doing esketamine in our clinic. So with partnering in terms of protocol development, and also just in our Wyndham aging kind of collaboratives, talking with them about kind of that old Vermonter mentality of like, I don't need help, stubborn, I'll do it myself type of thing. But we know we have mental health and social isolation issues. And so we've started the work of really saying, okay, like, how do we meet people where they are? We have Senior Life Solutions as a company. They've have a lot of clinics in the Midwest, but also just started in Maine. We've talked to 2 hospitals that have used them as kind of a staffing solution, but they help set up a program for intensive outpatient therapy for Medicare patients. It might be the right thing for us. It might not. We're not sure yet because we're still in the preliminary phase of investigation. But any way that we can reach people, I think Turning Point obviously does a great job for people with substance use issues. But when we're talking specifically about kind of mental health crisis, especially in our aging population, it feels like our toolbox is kind of limited. And so whatever we can do to expand our access, one of the retired physicians who was at Brattleboro, who's now, she's a founding member of Wyndham Aging, but she, in our meeting, our strategy session we had a couple weeks ago, she kept saying it's one bird at a time. And I feel like that has just stuck in my head of like, with our limited transportation and people being isolated and where they live geographically and social isolation, especially as their spouses are passing away and their friends are dying, it really does feel like a one bird at a time type of work. And I think also something that was really interesting to me, and this is coming from a Canadian who worked in public health for a while in Ontario before coming here, is that in all of our Winder presentations, I spoke with Bruce about this a bit, but even here in my new role, like, how are we engaging with our public health counterparts to figure out where there's synergy in our work? And we haven't fully explored that yet. So I'm hoping that there's opportunities there too.
Great. Well, thank you for answering the questions. I appreciate it. And thank you, Stephen. I enjoyed your responses as well.
Thank you.
Back to you, Chair.
Thank you. Any other board member questions for the Grace Cottage folks?
I can
Great.
jump in
And
with a cup. Sorry, I was
go ahead, Robin.
trying
Sorry.
not to jump the gun, but I'll jump in. I just have a couple. I wanted to hear a little bit more about your plans for Jerry Psych. You mentioned it in your narrative that this was something you were exploring.
Yeah, that's kind of what I was just talking about a little bit in terms of that Senior Life Solutions program. So the Senior Life Solutions program, Medicare specifically, intensive outpatient therapy, and it's a combination of one-on-one with a therapist as well as group therapy. And so Senior Life Solutions, if you kind of Google that, you can get to their website. They have a lot of, I think about 150 clinics in the Midwest. And so their penetration in New England is not very great right now. I think the main location, we just talked to their CEO and some of their staff members last week or the week before, and they've just started. They're just a couple months in. It's the question we have. So from a financial standpoint, there might be, it might be a small pickup in terms of our facility fees that we would capture on our cost report. The question we really have, though, is if we have the catchment area to support the program. If we have enough people, we could actually get invested, get on board. It's obviously sometimes difficult to find 6 to 10 people who are interested and available for individual and group therapy. It's a lot. It's like 3 to 4 sessions a week, depending. But their outcomes, as you would imagine, are fantastic. So if you can do that much therapy, you're committed to it, really, like, their engagement in the community, their engagement with their peers, it just is, it sounds like pretty life-changing for the people who can participate in the program. So we talked to a small critical access hospital in Wisconsin, and that CEO had actually started the program in Michigan at his former post, and then in Maine. So it's on our project tracker for our planning meetings. Chris is leading kind of that PMO initiative. So we'll continue to do due diligence work there. But if we have the catchment area, I think it's a great program. It's just whether or not we can make it work with quite a small, most of these places we've talked to, they're within like an hour of Milwaukee or within an hour of Portland. And so you're kind of like, oh, do we have enough in Brattleboro that we could swing it? So yeah, that's the due diligence place we're in right now.
Got it. And how long, I was just curious, like if you decide to either do it or not do it, when approximately when would you make that decision, and how long does it take to set up, that kind of thing?
Yeah, I would say in this coming year, we'll make the decision whether or not it's viable for us.
Yeah.
From their perspective, I don't know if I don't think we'd have, I'm just thinking there's some questions about kind of like licensing for space if it's delineated as clinical. I don't think we'd have that kind of barrier because we would have space currently licensed for clinical provision. And they will start a program with virtual therapists, especially for the one-on-one if they can't find someone to hire locally. I'm assuming staffing will be tricky for them, but they kind of laugh at us a little bit because they're like, you've not been to North Dakota, which I haven't. So apparently it's tricky there too. But so, they don't seem to be that put out by that. But I think for them, it definitely is a couple months off the ground in terms of staffing. And then really it's figuring out the referral mechanisms. So when we talked to Maine, they were saying from their inpatient, they also have a really robust swing bed program. So they kind of refer out of their swing bed. So when they're discharging that swing bed patient, they can get referred into the program as well as like their community health team or primary care referring into it. The other thing that's interesting for both of those people that we've talked to is they had no outpatient psychiatric offerings whatsoever, which I was like, wow, that seems crazy. So that's kind of like their one lever to pull for any Jerry Psych. We obviously have a therapist and 2 psych NPs, but they're very, very busy and they don't do that type of like intensive therapy. So perhaps that's another referral mechanism for us, into like getting more intensive therapy. So yeah.
Great, thank you.
Sure.
And then my last question was about the physical therapist FTE. It sounds like you've been filling essentially that position with a contractor agency staff. Is that right? Did I understand that correctly? Or is that net new?
There's 2. We have had one FTE this past year who is here as a traveler.
I see. Yeah.
And as I said, we're hopeful to replace that person with a staff member. In the budget, we added 1 additional FTE on top of that once we have the space to have that person be able to treat patients.
Got it.
We're so shortage on space right now that, as Olivia referred to, they've been so busy over there. There's been a couple of days in the last couple of weeks that it's a good thing we've been having good weather outside because some of the therapy had to happen outside.
That sounds kind of nice, actually.
It is if it's not a rainy day, but
that's true.
There are some things that you can probably provide better therapy outside, but they're literally tripping over each other in our physical therapy gym.
Yeah. And Olivia, I think you mentioned part of the additional PT was related to the wait times you've been seeing, but I didn't notice wait times data in your submission. If you've submitted that and I didn't find it in my email, then I apologize. But I was just wondering if you could talk a little bit about what kind of wait times you're seeing for PT and other services.
Actually, Crystal, I think you're probably still on the line, man. So do you want to talk a little bit about kind of the average number of patients you're seeing outpatient right now and how you kind of fit that in with the staff you have and wait times? Because it's so impressive.
Sure. Thank you. Good morning, everybody. So my goal for new evals getting in the door is within a 2-week window. We are currently booking, unless I get a cancellation callback, we're currently booking new evals just a little over that goal. So we're out 3 weeks, sometimes 4 weeks. So right now it's the middle of the middle of August. We're booking into the end of September. For some of our specialty services, those patients have to wait a little longer. Not all of my clinical staff is trained up in the same skill set. So for instance, women's pelvic health, I only have 2 practitioners, so people wait a little longer to get in for that service. And pre-COVID, I would just say, pre-COVID, we had a good day if we had an average of maybe 25 patients on average through the clinic. And right now, my daily average is 49.5. I want to say just under 50. There are some days here when I have more staff here when we're pushing 60, 65. Last week we had a 72 patient day here, and we're literally treating in the parking lot and in the hallway, and it's not ideal. And I mean, we're as safe as we can be, and patients have fun. It's good crew, but we need more room. And I can't grow the business, and I know there's business out there to be had, because we don't have enough space. So.
Great, thank you. Those were my two follow-ups that weren't already answered. Thanks so much for your presentation.
Thank you.
Any other board members before I turn to the HCA?
I have just a couple. As everyone else just said, thank you. I just have like a few specific questions left. In our workbook document, I didn't see your Medicare Advantage revenue pulled out separately, and I was just trying to figure out if that's in the commercial revenue or in the Medicare traditional revenue. It's
in the commercial revenue.
Okay. Do you think, can you break that out so we can?
I work with the IT department and the billing department to see if we can set up new financial classes going forward to try and be able to start tracking that separately. In all honesty, it was never, we had almost none of it up until very recently. And now all of a sudden we realize a lot of our patients have it and it needs to be tracked separately.
Okay. I think that's the situation for several hospitals over the years. So thanks. So I'm just trying to understand the swing bed reimbursements. Are they, how do swing bed reimbursements work? Are they DRG based? Are they duration based? And how do they compare to the acute admission reimbursements?
Depending on the payer, for Medicare, they are exactly the same way. As a critical access hospital, you file your cost report at the end of the year. They calculate the costs to take care of, one of the lines is the inpatient floor, which of course has both acute and swing, and they then divide your total cost for taking care of all of those patients by your number of patient days for the year in that category, and Medicare pays you your costs for their portion of taking care of those patients. In our case, truthfully, the Medicare and the acute and swing cost per day is almost equal. It's within a few dollars each year. For the Medicare Advantage, we, in essence, get paid exactly the same way. All of the Medicare Advantage contracts pay us throughout the year on our cost per day as calculated by the most recently submitted Medicare cost report. The only problem is that there is never any reconciliation. So if costs continue to go up each year, which of course in this current market inflation they do, with the true Medicare patients, part of that cost report submission is settling at the end of the fiscal year on your current year's fiscal costs. The Medicare Advantage, you don't ever get that. So if the daily rate goes up $100 from the previous cost report, you never get that extra $100 on any of those Medicare Advantage days. For the commercial payers, most of them are a percentage of charges the same way as the acute, the true commercial, not the Medicare Advantage, are percentage charges the same way as acute admissions are. For Medicaid, they have a daily rate, as referred to in that slide that Olivia gave us, and it's not nearly adequate for taking care of a skilled nursing patient. It doesn't take into account anything based upon what they actually might be having. And most of our skilled nursing patients here are getting intensive therapies, whether it be rehab or IV antibiotics or both, which are part of the reason you have such large write-offs on those.
Okay. With regard to the geriatric psychiatry discussion, sorry, I have to remember this. Serving, what's called Senior Life Solutions, sounds like a great program, and it clearly fills a need. I think it's probably pretty unrecognized for outpatient geri psych. I think a lot of, you may know I'm an emergency physician, so a lot of when people in my line of work talk about geri psych, I think a lot of people are thinking about inpatient for patients who have memory challenges and then some superimposed behavioral disturbances such that other facilities aren't appropriate. Is that a a potential need that you've looked at trying to fill, and is that, and what are your thoughts on that?
We have not. We've not actually started any conversations or process in terms of looking at inpatient geri psych. We don't have any inpatient psych safe rooms currently, like psych safe as I'm used to, as I'm used to them in a larger facility. We do have one in the ED. I don't know, Stephen, historically, has that ever been a conversation?
Not to my knowledge, no.
It's definitely something we look at.
Yeah, I wouldn't propose that I understand the economics of that either. So I was just curious if that was part of the conversation, though. And then one last ED follow-up question. You mentioned that a lot of patients come from, do you think the growth may be from patients who are coming from far away? Do you track at all where patients are from, their home zip code when they come to you? Because, this sort of gets into the sort of conversation about, could you divert them, and if they're your own patients, you can, doing great primary care, you can hopefully keep them from going to the emergency department in the first place. But I was just curious if you understand where geographically your patients receive their primary care or are primarily from.
We should be able to. Oh, sorry, go ahead, Chris.
So we have done this work. We're always doing that work in terms of a panel analysis, from a population health perspective. But in terms of ED volume, we've done the work in the past where we've looked at triage and we've looked at panel, essentially meaning if a patient is owned by one of our primary care physicians and they've been seen in our ED and they have a triage level of 4 to 5, then we have looked at those. We are starting to look at those again, especially as we continue to evaluate implementing a same-day program.
All right, thank you. That's all I have. Thanks, everyone.
Thank you. And I'll turn to the healthcare advocate.
Good morning. Thanks so much, Sam Peisch with the Office of the Healthcare Advocate. Welcome, Ms. Sweetnam. A couple questions. I wanted to thank you for all the work, your hospital for all the work you've done coming into compliance and working with our office on Act 119. I know we have a couple questions about a couple of kind of exclusions from the policy, but I think we'll follow up and not do that because it's too technical in the hearing. I want to ask you at a high level, I think Grace is unique in its level of commitment historically and investment in primary care. And I'm sure you're aware that some people from a financial perspective criticize hospitals for owning primary care just as like a, losing money from a losing money perspective. I'm curious, I imagine you've, looked at that. I'm curious how you respond to like criticisms of that.
Well, I think for us, and as you said, I think like the commitment to the community and our commitment to the overall health and wellness of our like community broadly defined here is the most important thing. I think I've never been anywhere where we have primary care providers who might run out to a nursing home and see a patient or might run and do a home visit. Like remarkable. And of course, that doesn't happen that frequently, but the fact that our providers are willing and have so much ownership and feel that closeness with the patients, I think is why our patients are so loyal and like satisfied with the care here. I think they can tell that the people who care for them are quite devoted to them and, you know, committed to their well-being. So for us, I think it's just the way we do business. I mean, I think primary care is always going to be the cornerstone of the care we provide here. And you know, our swing bed program and our rehab program. I mean, rehab, the type of rehab Crystal's discussing on the outpatient side, that's really like holistic well-being that we're talking about. You know, it's so part and parcel of the primary care picture. So, yeah.
No, thank you. That's helpful. I'm curious just if you mapped out what your commercial rate and NPR increase would need to be to get to a 0% operating margin. I'm curious if you did that exercise or not.
No, I did not.
Okay. And my last question is a little bit technical. I apologize, but I was interested in your community health needs assessment, your implementation plan. And there was something in there about depression screening, which it says you do for everyone age 12 and above, which I think is great. My only concern with that, and this came up actually a little bit in the OneCare hearings, is they had a similar like mental health screening pilot. If you screen a lot of people, do you I'm hoping that you feel like there's enough providers to see these patients? Because I mean, one thing, as I imagine, you know, if you screen more people, you're going to document and identify potentially more need. So I'm curious about that, if you thought about that issue potentially.
Yeah, I think it's a really, really good point. I think on our inpatient side, whenever we're screening for mental health or kind of acute, any, you know, delirium, depression, any of those screening criteria tools, helpful for the way we're treating patients on the inpatient side during their stay. Obviously, referrals on the outpatient side become a little trickier for ED or primary care as well. I know nationally, and I know Bruce talks about this in his presentations, nationally, there's a need and we're no different here. I would say that Meredith, our therapist who's in the clinic, is extremely, you know, skilled and talented and also very flexible for us. So sometimes if we're pulling her up onto the floor to see inpatients, you know, she will fit those in when she can, but that's not a systematic approach to the larger need. So I think we do as well as we can, knowing that there's a community shortage.
Those are my questions. Appreciate it.
Great. Nothing else from the board. So thank you for your presentation and your time this morning. And we can adjourn and we will go off the record and we will be back at, I think it's 12. 12 o'clock. So we'll adjourn until 12 o'clock. Thank you.
Thank you all.
Thank you. Bye-bye.
Thank you.